in the room and online, and it gives me great pleasure to welcome both Amina Yaqin and Dr. Farah Nazir, and also the whole team who are both present in person and online. Amina is based in the English and Creative Writing department here, but in a way, the team here is representing the really interesting, intriguing project, Empathy, Narrative and Cultural Values, which explores the complex dynamics of narrative perception and empathy amongst South Asian Muslim communities in the West Midlands, and has, very pertinently for our purposes, a kind of strong medical humanities strand to it, in the sense of the team has been working with cancer champions and cancer patients in those communities, and examining how faith and cultural values play out, are used and made in the various conversations and actions around cancer. And so how kind of empathetic engagement and solidarity can be supported in these very important community health settings. But I think that the team is going to present as a team. So however you want to do it, go for it.
Thank you, Rebecca, and thank you to the Centre for having us here today, and to all of you here, and hi to everyone online. So I'll just start with introducing the team. Dr. Farah Nazir, who is our postdoctoral research associate and joined us recently, and the other postdoctoral, she's the Exeter postdoctoral associate, I should mention, and our other postdoctoral associate is online and is joining us from Birmingham, Dr. Eva Mumtaz. Eva, do you want to give everyone a wave? And we have Professor Peter Morey, who is based at Birmingham as well and is joining us online. So that is, he's the PI of the project and I'm the co-I of the project. It's funded by UKRI, AHRC. We've got the logo on to make sure we are compliant with the funders' regulations. So I think I'll jump on to the next slide about the project itself, because what we're going to do is we're going to rotate between the four of us for the presentation. So please bear with us. Some of this will be with me and Farah here, and some of it will be picked up by Peter and Eva online. So I just, with regards to the background to the Empathy, Narrative and Cultural Values project, I could say a lot, but I thought I'll just say something very quickly and let Peter speak to that in a minute. What I want to say is that we're deliberately not referencing quantitative health data on ethnic minority communities in Birmingham to kick off our presentation. Our aim is to highlight a granular study that doesn't work on an extraction model, and our purpose is not served by showcasing a particular community as a burden on the public health system. We are working toward a structural approach that moves away from racial othering, and what we are interested in are cultural values from the bottom up and how people connect with each other in a multicultural environment shaped by intersectional inequalities. Our community-centered approach to how health decisions are made by community members is shaped by a participatory method, and this relies on co-creation and co-production and ethical considerations. And I would like to acknowledge all the cancer champions, the cancer patients, and the Green Lane Masjid welfare team who have helped to shape this research. So I think those are the sort of, the overview of the project has been really the importance of empathy to healthcare acknowledged in recent research, and empathy, Peter again will talk more about that, so I'm not going to go into that in detail here. And the other sort of context we look at is how faith and cultural values shape Muslim patients' engagement with health narratives because of our location for the study, which was Green Lane Masjid, and the unique resources that exist within communities, their spaces and modes of expression in relation to managing healthcare decisions and various communications that they encounter along that journey. And moving, I think very importantly, which is a model that's used quite heavily in medical sort of knowledge production, the universalist model. So moving beyond the universalist model to a more culturally informed one that is sensitive to the needs of those who are the targets of these types of interventions and improvements to healthcare. And what we have done as part of our there are several outputs, but what we thought we'd talk to you a little bit about in this presentation is the idea of translating insights into a transferable toolkit for community-centered care. So I will hand over to Peter for the next slide.
Thank you, Amina. I hope everyone can hear me okay, and thank you very much for the invitation to be part of the presentation today. Really, my role just in this point in the presentation is probably to set out the sort of direction of travel and also to do a few definitions. So that's what I want to do. But we thought it might be useful to begin with the research aims, broadly speaking, of the study. Obviously, our main interest is in the question of what role empathy does and can play in healthcare narratives for South Asian Muslim patients and caregivers. And along with that comes the question of the barriers that might exist towards building those kind of relationships, to narrative engagement in healthcare. So it's a two-way thing. On the one hand, it's communities speaking within themselves, but then, as Amina said, with regards to the toolkit, the question then becomes, how can we realize some of these findings in actual practice, which is where the toolkit idea comes in. And again, broadly, how can narrative-based strategies improve communication between South Asian Muslim patients and healthcare professionals? The one kind of caveat that I would put in here, as I think Amina has indicated a little bit, is that in moving away from a broad-based or universal model, we also want to be equally sure that we're not giving the impression today that we're talking about the way that South Asian Muslim patients all react to cancer, because obviously there's no such thing as a singular model. Nevertheless, these are the trends that we found. So I'll go on to talk a little bit about empathy in healthcare very briefly. I'm sure many of you would be familiar with this. Empathy in healthcare has been the subject of quite a lot of scholarly attention in the last 20 or 30 years or so, all across the world, particularly in Britain, Europe, and America. And numerous research projects have shown that more empathic healthcare can improve patient experience and even in some cases outcomes. So, for example, in a 2013 Dutch review paper looked at almost 1,000 studies of empathy, and it defined empathy in the health sector according to this quote. It talked about the competence of a physician to understand the patient's situation, perspective, and feelings, and to communicate that understanding and check its accuracy, and to act on that understanding in a helpful therapeutic way. This report also concluded that studies of empathy in healthcare, the ones it was looking at, revealed quite a strong correlation between physician empathy and patient satisfaction, and a direct positive relationship with strengthening patient enablement. They found, in other words, that empathy lowers patients' anxiety and distress and delivers significantly better outcomes. At the same time, or in this period of the sort of first 20 years or so of this century, various practical initiatives have entered the field of healthcare to augment empathy, in part as a response to that move towards, or as part of the move towards a more person-centered care approach. In 2014, the patient charity organisation National Voices produced a report which talked about how person-centered care should look by 2020, and that had empathic understanding at its heart. Well, now, of course, when we think of 2020, we probably remember it as the year of the global COVID pandemic, something which placed unprecedented pressures on health provision around the world and overturned many existing plans. In addition to the way that minority communities found themselves disproportionately affected by COVID in terms of infections and levels of mortality, there was also a sense that some communities were harder to reach than others, with messaging about the need for isolation and later vaccine take-up. And that mismatch and the pervasive stereotypes it sometimes reinforced was one of the inspirations behind this project. Empathy, Narrative and Cultural Values follows on from two previous projects that Amina and I have led, the Framing Muslims project from 2007 to 10 and Muslims, Trust and Cultural Dialogue from 2012 to 15. What they all have in common in very different ways is seeking to cut through the negative generalizations and media and political framing to find out a bit more about how cultural values actually work within sections of the Muslim community. So this project is in a sense a continuation, albeit with a slightly different focus. And here, as Amina said, we're looking at one part of the Muslim community in Birmingham and how they come to incorporate their own values into health decision making. So our focus has been on those affected by cancer who use the welfare service at Green Lane Masjid in Small Heath, Birmingham. And I think on a later slide, there's some sort of demographic details about that community. We asked, what can we learn from the narratives that are shared when members of a community speak among themselves? How are such narratives articulated? What do we need then to create empathic spaces where this kind of story sharing can happen? And also, how can health professionals and third sector stakeholders benefit from a more culturally sensitive understanding of what moves these community members in their experience of cancer? And so, as you will be seeing today, to undertake that research, we've assembled a team with first-hand knowledge and lived experiences of the cultural frameworks of the South Asian diaspora, and with particular linguistic competencies related to Urdu, Punjabi, and Bengali in particular. And so our understanding of culture then is informed by Arjun Appadurai's emphasis on its dimensionality rather than substantiality, so that cultural differences are situated differences, he says, that either express or set the groundwork for the mobilization of group identities. And a number of critics have talked about culture as being layered, with the outer layer comprising manifestations like artifacts, products, rituals, language, and the core layer consisting of underlying values and basic assumptions. And I could give you a list of the names, but that'd be too long. For our purposes, we define a cultural value as a judgment that's based in or influenced by the norms of the community in which one feels part. Cultural values, crucially, are relational rather than fixed and are often linked to feelings and actions. They're shored up by social interactions and relationships, group values, shared goals, and common sensitivities. And taken together, they inform a sense of what it's appropriate to feel in a given context. And that's true of all group dynamics, really. We discovered that the unique resources for the creation and maintenance of empathy were held within communities themselves, in the spaces they inhabit, and you'll hear more about the physical space in a minute, and in the common idioms and frames of reference, often drawing on Islamic texts and doctrine, found in the narratives that they shared with each other. So empathy was created and maintained through common frames of reference and via the ways in which participants express themselves in conversation with other community members. And so we'll now go on to highlight some of our findings. Prominent among them, I think, is the fact that cancer, as you'll see, is not simply an individual, but a community experience in both negative and positive senses. Negative in the myths and stigma surrounding a cancer diagnosis, which may affect the patient and their extended family within the community. And positive in that we discovered something about the range of ways in which sharing narratives and conversation along the cancer journey increased empathic interactions and provided means of support and affirmation. So now, thank you, I'll pass over to Eva, I think, who will take you through some of the more detailed stuff.
Amina.
No, sorry, it's me. Okay, thanks, Peter. So I will just talk to you a little bit about our methods. And this relates to our data collection and the analysis. So as Peter mentioned the project location was Green Lane Masjid, which is in Small Heath, and we'll show you a visual of where it is in a minute, which is quite concentrated area for inhabited quite with a large number of South Asian community members. And here we worked with the masjid they have already in place the Macmillan Cancer Champion Program, which is a nationwide program. And we had, prior to setting up this work, when we were scoping out the study, we had been in conversation with the cancer champions already. And the person who was kind of in charge of the Macmillan program at the masjid. And the feedback that we received was just that the cancer champions start to feel a bit disengaged as it goes along. And it's about sort of how do you sustain recruitment and engagement from the sort of people who are supporting other community members through a very challenging part of their diagnosis and illness. So what we then did was we worked with the masjid's welfare team and recruited cancer champions and cancer patients, and these with ethical sort of considerations both from our side and from their side. So it was a fairly long process. The setup took nearly, I think, 8 months to sort of set up, but it led to 47 conversations over 13 months with patients and caregivers. So cancer champions as well as caregivers could sometimes be a caregiver. And then to kind of respond to the problem of recruitment and sustainability of the champions throughout the program and keeping them engaged, we added 4 focus groups for champion development at the masjid, which we helped to, I suppose we moderated them, but they were, in a sense, quite useful as a means of reflection and development for the cancer champions, and allowed people to reflect back on their conversations that they'd had. And each cancer champion patient or caregiver would have a set of 6 conversations. And you have 47 because unfortunately one of our patients passed away in the sort of process. So it's the nature of the disease, and I think you live with that kind of context throughout this project. We then, using the conversation method, we recorded all the conversations, and as researchers we would be listening to them and using qualitative data analysis using NIVO. And this has been very fruitful, and we found that when participants were given structured empathetic space, patients articulate layered narratives that integrate illness with family, duty, faith, fear, and identity. And Eva will talk to you a little bit more about the space as well. We achieved this by carefully and systematically designing a program that incorporated, as I said before, the tailored cancer champion training, targeted and personalized prompts. The prompts were really helpful. The cancer champions, in an initial conversation, indicated that they found that they wanted some support in terms of, am I doing the right thing? Am I having the right conversation? Is this the way? Just really simple things, but just some support, to think aloud, to talk about it, to kind of work on themes. And obviously for us, we were tailoring the prompts a little bit around the kinds of questions that we were also interested in exploring. But I think I should reiterate that this was always done in a consultative way and not in a kind of way that we were imposing those kinds of contexts on them. And I think the fostering cultural humility was a very important part of that, in terms of it's a mixed group of people, and like Peter said, Muslim community is not a singular thing. It's a very big, diverse communities, and there are I mean, we are in a particular setting of Green Lane Masjid, but the masjid itself is a setting in which you get a demographic which is quite coming from different parts of the kind of faith. And we have overall in Birmingham, according to the 2021 census, 29.9% Muslim. And in Small Heath itself, the 85.9% of residents identify as Muslim. So that's just to give you an idea of what our demographic was in relation to the to the masjid setting. So if we, and that's the Green Lane Masjid itself. You can't see it, but on the opposite side is a big Morrison's. And it is like we entered through the front, through the side doors, where the patients and the cancer champions would sort of go to do their conversations and have a dedicated kind of time. But it's been, I think, also a learning process for us to have been in that space and to experience with the welfare team the different kind of challenges and contexts that came up as we went along in terms of changes to leadership as well, and how that impacts a kind of research study. But anyway, if we go on to the next slide, just to give you a sense of the participants. So because it's a granular study, we don't have like large numbers of people participating. We have these are the numbers of the demographics, sorry, of the participants in terms of ethnicity. You will see a large contingent of Pakistani participants, Somali participant, British Tanzanian, Indian, British Bangladeshi, Black African, Arab, Asian, other. So you've got a multi-ethnic Muslim community context. I think it gives you a real flavor of the kind of diversities. And there's also, if we go to the next slide, you'll see the kind of diversity across the champions. And here we're sort of looking at the context of diversity through language as well, because language, obviously, there's a shared kind of spiritual language in terms of Arabic, but then there's the demographics here of English, Urdu, Somali, Arabic, Punjabi, Mirpuri, Hindi, Bangla. So you'll see Urdu is the sort of next highest one, and then Somali is pretty similar, and going on to the others. So all of this gets reflected in the conversations, and Farah will talk a little bit more about that in her analysis. So we'll move on to the next slide, and I'll hand over to Eva.
Hi, everyone. I hope you can hear me okay. Thank you so much for having me. This is really exciting. I've never done anything with Exeter before, so thank you. So yeah, I'm going to draw on what Peter said earlier. So cancer, we found, is a community experience. So we found that cancer experiences within the Birmingham Muslim community are shaped not only by clinical pathways, which determine what happens medically, but by relational, spiritual, and cultural frameworks, which shape how patients interpret and respond to care. So for our patients and caregivers, cancer is experienced not only, same slide, sorry. Cancer is experienced as a whole life event, not simply a clinical diagnosis. Participants in our study consistently integrated illness into wider narratives about family responsibility, identity, work, faith practice, and community roles. Diagnosis was not simply described as an isolated medical moment. It was described as something that changed relationships, routines, and future expectations. So this reinforces that effective engagement cannot focus on information delivery. It must recognize the broader social and emotional ecosystem in which patients interpret illness. So when thinking about services offered to patients and caregivers, then this suggests that relational awareness, not just clinical clarity, is central to building trust. So next slide, please, Farah. So faith as a coping framework. So we found that faith emerges not as a single belief system, but as a set of practices, routines, and meanings that support coping and resilience. The coping framework operates through daily practices, such as masjid attendance and pilgrimage aspirations that they may have, so Hajj and Umrah, and theological interpretations on suffering and communal belonging. Our findings reveal that faith-sensitive approaches can deepen engagement and understanding when handled respectfully and without assumptions, so with cultural humility. Where conversations allowed space for faith to be articulated on the patient and caregiver's terms, we found that emotional depth and engagement increased. So importantly, Participants did not want assumptions made about them. What they valued was respectful openness and cultural humility. Thank you, Farah. Next slide, please. So next we move on to faith settings as a trusted health resource. So a particular significant finding relates to the mosque setting in particular. You'll see the picture on the right. So that's the welfare room at Green Lane Masjid. So it was designed to be purposefully non-clinical looking and also not to feel like a masjid itself. So that helped our patients and caregivers and champions just relax, you know. Through our close collaboration with Green Lane Masjid, we demonstrated how mosques are not just venues, they are trust networks. Location really matters. So in our study, locating conversation within the trusted masjid environment enhanced comfort and continuity and openness. We observed repeat engagement across all conversations at Green Lane Masjid. Participants described the setting as supportive and safe, both emotionally and spiritually. So I have a little quote here from a patient who said that, and I quote, "I think this is probably my main support. I've not really gotten any support elsewhere apart from just some family and friends. So this is the main support I've had throughout this whole time. And it's filled a void that I couldn't find anywhere else. So it's been really good to me." End of quote. So our research exemplifies how mosques can function not simply as venues, but as trusted community health resources. Partnerships of this kind have clear potential for strengthening early engagement, awareness, and sustained participation in health and cancer-related initiatives. Good partnership models can improve engagement in screening and awareness is what we also found. So next slide, please, Farah. So our final insight concerns trust. So trust is built through micro interactions. Participants' experiences of healthcare professionals were shaped not only by treatment outcomes, but by toned listening, clarity, and perceived respect. Positive micro interactions reinforce trust, whereas moments of dismissal or lack of explanation sometimes led to disengagement or exploration of alternate approaches. So I want to quickly show you a diagram here that we've named Alternative Information Ecosystem. So here, you can see loads of things on the diagram, such as traditional healers, hakims is another word for them that they may use predominantly in like Pakistan and Bangladesh. So community members, extended family, friends, content creators. So these are all things that people may tap into to get their information alongside their medical, typical pathways. So these parallel knowledge networks can influence thoughts of risk perception and underlying fears not fully addressed within clinical conversations. So most participants described complementary or traditional practices as supplementary to clinical care. However, interestingly, in one case, a participant discontinued prescribed treatment after beginning it. So she was prescribed some like after chemotherapy, some tablets that she had to have for 10 years. However, she sought advice from traditional healers and decided to stop that treatment and have alternative herbal remedies instead. So she expressed strong concerns about chemotherapy and its effects, and this was not framed as a religious requirement, but something deeply rooted in her fear and mistrust of side effects. So while this wasn't a dominant pattern across our dataset, it illustrates how parallel information networks can shape treatment decisions and reinforces the importance of early, transparent, and relational conversations. Thank you. I'm going to hand over now to my team.
Hey, that's me, guys. So I will be the clicker and the presenter now. Yeah, actually go on then, yeah. Okay, so we're moving on to the aspect of language now and code switching. So we're using a case study example because I'm still going through the data and doing some analysis. So this is kind of like just show you a little bit of what we have going. So we have a champion, some patients, they're paired together, and sometimes those pairs end up speaking similar languages. So in this case, we have a pair, a champion and patient that speak English and Urdu. They also have other languages in their repertoire. So they have Bahari, Patwari, also known as Punjabi or Zikri, and I believe that one of our champions also had Pushto. Yeah. So they have these different languages. And then because they could both speak them, they alternated. So that's what we define as code switching. You alternate between English and Urdu. They also used and drew on Arabic origin religious formulae. So things like inshallah, God willingly, alhamdulillah, and mashallah. So they switched from all these different types of phrases and words. So the question we have then is, are these shifts random or are they socially interactionally meaningful? Do they speak to anything that we've already seen? For example, we looked at interactional meanings such as tone and so on that Eva discussed. So yeah, let's move to the next slide, and the answer is, let's go to the next slide.
Oh, sorry. Slide clicker's not working.
Yeah, so in short, the answer is whenever there's like any kind of linguistic shift, it's meaningful. So that could be grammar related, and fortunate, unfortunate, don't worry, I'm not going to focus on grammar today, but we're going to look at social and discourse functions. And here there's many factors that motivate code switching. I'm going to just focus on these for now, but I will be expanding on this in more data collection analysis that we're doing. So discourse organizations, that's quite straightforward. For example, how you start a session, it might be in English, or it might be a change of topic into another language like Urdu. A speaker positioning, so holding your stance in a particular language might come up. A speaker identity construction. So identity construction can be faith and cultural identity. That's like a really obvious one, but there's also medical identity, and there might be more than one medical identity in our patients. And then also relational alignment, and that starts to speak to empathy part of the project, as well as emotional positioning. So that could be proximity, which is probably a natural one that might come up, but also distance, and is that reflected in language? So if we go to the next slide. Okay, so before I talk about and give you some examples of what I've seen in the data, I just think it's good to have a look at what the functional distribution of the languages are. So English carries this biomedical, institutional, narrative type of scaffold. And then Urdu intensifies moral, relational, and cultural grounded meaning. And then Arabic and origin faith expressions invoke this sacred moral framing. So you would think this is a very nice complementary distribution. But as you will know, particularly if you speak different languages and you speak multiple languages, it's not always as crude as this. So what I mean by that is this is a good kind of overall, perhaps, discourse organization. These languages share multiple functions. So I'll look at those functions now in the next slide.
Okay.
Yeah, it's that one. So going back to those factors, so we know that code switching is not random. When we use it, it's always motivated by something. So in our context, we're looking at discourse interactional meanings, but also there's a whole pragmatic type of factors as well, which is not the main focus for this data. So discourse organization, so we have today is our 6th session. This is a very structured clinical way of introducing the clinical setting, I guess, in a way, even though it's not a clinical setting, but it is connected to like Macmillan and so on. And then we have English. And then here we have Urdu, so you have Ayurveda treatment, mein dekh rahi thi video. So Ayurvedic treatment, so some of you will already know this, it's an ancient Indian medicine. It's not so ancient, obviously, it's still used across the subcontinent, including Pakistan, which is the heritage of our patient and our champion, but also very trendy now in the global north. Very, very trendy. It's in all sorts of stuff, hair products apparently as well. So here she switches for a topic. She goes to Urdu as soon as she starts to talk about Ayurvedic treatment. And then, she talks about herbs. Some of the herbs she doesn't know the name of. In Urdu, also she doesn't know the name in English, so there's a lot of that switching. Speaker positioning. So here the patient is saying, I did research, the oncologist said. This is very much kind of making her stance on the fact that she has formal biomedical knowledge. She knows this kind of this information, which this particular patient emphasizes a lot in the conversations. And that's in English. But then she goes on to say, "Main surgery nahi karna chahti thi." So that means I didn't want to do surgery. So that is used for Urdu, and that's a very strong affirmative stance, and she uses Urdu to say that, not English. Identity construction. So again, we know I mentioned earlier that there's a cultural identity, there's a faith identity. These are like really obvious things for why we code switch. What I was really interested in the conversation was that she also uses English to align with her NHS. She's an NHS patient, right? Getting cancer treatment. And she uses English to talk about those things. So I want to speak to the Macmillan nurses. And then when she's talking about alternative medicine, so here in Urdu, she says, Hakim ke alaz. So Hakim is a herbal medicine practitioner, and it's rooted in Islamic knowledge and principles. That's what Hakim means. And so here, Hakim ke alaz means Hakim, a herbal practitioner treatment. So here she's using Urdu, and I think what's really interesting is that these two identities of hers coexist. She has this very cultural and spiritual based holistic kind of approach to her cancer treatment, but then also she has her NHS modern medicine patient facing identity, and these coexist. And as Eva was saying earlier, there was a patient that stopped taking medication. I think it was this patient possibly.
Yeah.
Yeah, it was, right? Yeah. So in terms of relational alignment, again, this is looking at empathy, but also emotional positioning. A lot more, I need to do a lot more analysis on this. But things like this is a champion now speaking, it's a really difficult time for you. This is a very professional way of communicating some level of care or empathy. And she uses English to do those things. And then we have in Urdu, the same champion then says, Allah give you shifa, inshallah. So that shifa, just translating that, the literal meaning for shifa is an Arabic origin word, but it's come into Urdu for a long time ago. It means cure, cure, some kind of healing or cure. There's lots of connotations to shifa as well. So usually a holistic well-being, that we use lots of different words, like health and well-being. We have many different words we use for it in English, but shifa has those connotations. But the kind of literal meaning is cure. So she shifts to Urdu for this, and it's a very it's a very strongly embedded in this kind of spiritual faith, even cultural too, type of empathy that she's giving here. So these are the two kind of different ways she's done that. So now moving on to the Arabic origin faith expressions. And so inshallah means God willingly, mashallah means what God has willed, alhamdulillah means praise be to God. And these are really interestingly used across discourse. They're also discourse organizers, but I haven't focused on that today because we need to do a lot more analysis to bring that up into a talk. But these are used in the cancer care conversations to express and frame illness through faith, hold gratitude alongside suffering, manage uncertainty, signal shared belief, and protect dignity, which I think is a really interesting one, the protecting dignity in illness. There's a vulnerability, and then it happens to be that she might use something like inshallah when she's unsure about the future, so God willingly. Alhamdulillah, praise be to Allah, when she's in pain, she might use that, and so on. And there's some work already on this by Fatima Regina, where she looks at how these Arabic faith-based expressions intersect with the Bengali language in the UK context. So she looks at it very much in the South. And I think what she concludes is that Arabic operates as both a sacred and social language, these particular phrases. So we're looking at how these particular phrases intersect with Urdu and English, because they're throughout the discourse. They're not just used by this particular pair, they're used by different champion and patient pairs. Okay, and that's over to you, Amina.
Okay, great. So I think
so this is just about translating I think the whole slide is into translating insights into a transferable toolkit for community-centered care. So as you will have seen in the kind of different scenarios that we've sketched out for you, is that there is some training of personnel that is involved in relation to that. For example, in the last session, there are points where the champion can feel quite conflicted and the patient and want to sort of guide the patient in certain ways, but obviously they hold back. But then there is that sort of, how do you manage all of that? So there were we developed our own particular training, which was kind of a faith-based model, as well as training that was supplemented by Macmillan, as well as the cancer research. So we did all those trainings as a sort of group ourselves as well, to get to the point of our training, to understand what was needed for that. And then to develop culturally sensitive, we've developed culturally sensitive support resources. For example, the prompts, we're working on the FAQs, and we'll be doing some video resources and visual aids with the GLM sort of team as well. And that's to show people like 2-3 minute conversation, modeling 2 to 3 minute conversations. So you get quite a lot of that on the different kind of cancer research charities things, but this one is going to be very community centered. So it'll have a different kind of approach. And it's about sort of mutual developmental support in a safe space. And again, also the guided reflection and discussion, the sort of focus group modeling as well, that will be included in the toolkit. So those are the kind of key points that shape our toolkit. And if we'll go to the next slide, sorry, I'm going to rush because I know you're all patiently listening and we're nearly at the end of, out of time. So the implications for the West Midlands and beyond, I think the full slide is not coming on. It's about, we're really currently in, sorry, on the wrong slide. So addressing the health inequalities for the West Midlands, you know, are and beyond, we are working through collaborative community engagement and narrative-based strategies, contributing to person-centered care initiatives, strengthening community and third sector partnerships. Our work really underlines a community-led approach, empowering local groups to manage their own behavior change, not through exceptionalism, but through compassion and care. Improves mental health and well-being. It delivers an innovative and inclusive conversation method, which I'll talk to you a little bit about, and empowers minoritized voices. Now, what do I mean by this? We're not advocating a generic South Asian or Muslim categorization, as our conversation method has shown, that complexities of individual contexts, and our aim is not to racialize specific groups. Our conversation method helps to demystify stigma around health behaviors from within, rather than stating particular groups as exceptions to be placed in a generic category in cancer care. There's our work emphasizes the need for an intersectional approach, taking into account gender, ethnicity, race, and class, with cultural sensitivity and a nuanced approach to empathy. And we have this kind of enhances trust in services as well. And I think that's really one more thing I just wanted to say about the method was that our method is co-constituted and co-creative, you know, with the light touch prompts inflected with the champions' voices instrumental in highlighting objective, reflective, and interpretive responses to the community cancer journey. The focus group helps to shape the reflective approach to cultural humility, including relational cultural values, incorporating faith and spirituality, culture and identity, well-being, and mental health. So this is really about a project that has explored the diversities of language, emotions, and behaviors within communities, within the Muslim community in Birmingham. I'll stop at that point. Any questions? Oh, and we have the, we do have a symposium in June, if anyone's interested, stakeholder symposium on Thursday, 16th of July, not June. If you're interested, please get in touch.
Thank you, team, the whole team. Thank you very much. Yeah, for that really fascinating presentation and really interesting work in all sorts of ways in terms of both some of the specifics, but I think also some of the generalities in terms of thinking about community and so on as well. People online, if you want to ask questions, I can. It would probably be easiest if you put your hand up, or your virtual hand up, although I will try and keep, somebody will keep an eye on the chat.
Yeah, I'll do it. Yeah, that's fine.
I think there is a hand up.
Yeah, we do already have a hand up.
So,
But I will also,
questions?
if there are questions or comments in the room, then I had a very general question, which is a little bit cheating because it's but it's a topic that just fascinates me in general, is when you're doing your linguistic sort of analysis, to what extent do you think that words that you label as English or Arabic might actually equally be labeled as Urdu? In a sense, I'm thinking about this from my own experience and kind of.
I can see why you might say this question.
Yeah.
Hearing about what the kind of work
Yeah,
they do.
exactly.
Yeah,
You
yeah.
know, what does
Yeah.
a Greek or whatever term?
Yes.
So, is the Urdu for oncologist actually oncologist? Is it? I mean, I take that as or
Yeah.
whatever. I'm just.
Yeah.
I mean, obviously, there's a sense in which you can still analyze it and say it's English. It's interesting that the words, but there might be a
It's
sense.
slippery slope though,
yeah.
that one. I think, shall I take this one, right? So I think the question you're kind of asking is this code switching versus borrowing distinction.
Or that somehow, you know, all languages are kind of connected.
Yeah.
Yeah.
I mean, I'll let Farah answer it, but there's one sort of example, if I can throw in relation to cancer diagnosis and especially screening, for example. We came up with this in relation to translation because I was helping out with cancer screening video for cervical smear and for bowel cancer. And we're talking about borrowing, right?
Yeah.
Borrowing in language. So Urdu is a hybrid language. It's
Yeah.
a very hybrid language. It's a modern language as well in sort of the history of languages.
So English as well in that sense.
In that sense, it's sort of the purity of its words or its contexts are quite difficult to determine, but certain words that are used in sort of medical contexts or contexts of defining the body. So for instance, going back to the example of the cervical smear testing, the word for vagina, you don't have like an equivalent. So Urdu turns to Persian to find the equivalent to then sort of put it in. And that equivalent was quite problematic because it was kind of coined in the context of shame. Like a woman's painful part of the body. Now, it depends, how do you understand shame? I know there are people around here who do a shame project. So it's, you know, like it can be seen as empowering for certain contexts and disempowering for other contexts. And in a sort of Western context, it's very different, the relationship maybe to shame, that it is in a South Asian context. So in that sense, the borrowing actually helps to neutralize the cultural value of the word, if that makes sense. But maybe that wasn't the question you were asking, but
very interesting.
Also,
yeah.
I think it's really difficult actually to separate languages that are so closely related. So my work is on South Asian languages, and it's really hard to separate them even. So it's like this big, we know this like world language continuum we have, don't we really? I think there are ways to do it phonetically, phonologically. Certain patterns only work in certain languages. So I've called the Arabic, these ones, I've called it Arabic origin, and I'm working on a different paper on code switching at the minute, and a colleague of mine who's senior to me, we decided let's call this Arabic origin faith expressions, because they are definitely not Arabic. So, you know, it's not an Arabic language happening here, but there is that connection to Arabic, and it's still quite distinct from the Urdu and the English. So it's really hard to make those distinctions. It's very blurred. It's fuzzy boundaries.
Well, it depends also where the person is coming from. For example, in the example Farah was giving you, the patient is Mirpuri and the cancer champion is Pashtun. So your experiences of Urdu are completely different, how you would use them and appropriate them. So I think there's another layering to that as well within sort of language borrowing and.
Yeah, but I think it's very hard. Most people, if you're doing a hardcore linguistics paper on code switching, you make acknowledgement of borrowing. You can look at like high frequency words. There's loads of like criteria that you can use, but really you don't know, because it's such a continuum. We don't know where one started unless it's very clear. This is a Persian heritage. Often what you see is Persian Arabic loans, borrowed items. You can't even separate Persian and Arabic. So yeah, it's very difficult to do that, but I think there are ways that I use. For example, when I'm looking at the difference between Punjabi and Bahari Patwari language, which are often bundled under one, but they're not. They aren't separate. So the grammar can give us it, and specific words, phonology, and high frequency. Those kind of things can help separate, I think. But it's enormous amount of work, and it's also you don't get anywhere. It's just like you just kind of go round and round. Yeah.
So we have
another question, and I think there was a
Yeah,
question there.
okay, yeah, and then we'll go online.
Yeah, it was a really great talk thing. I just my dad was Bengali and he died from sorry.
Oh.
No, from and being around lots of code switching my whole life. Yeah, it was just really interesting. But one of the things I could never translate to him when he was dying was he felt like he was failing and in terminal illness. And I was wondering about your toolkit and if there was like, because for him, like always strive, always do. And if that was something either to put in it or to if that was something you encountered or and I just couldn't there was no idea of surrender for him.
Okay, and can I ask, was your father suffering cancer or?
Yeah, terminal cancer.
Terminal cancer, okay. So I wonder if our sort of Eva might want to come into this as well. I think it's what we find with the champions and patients and the caregivers is that sort of connection in terms of, I mean, I don't know like what the sort of personal journey is. It's always different for each of the patients, but what it's quite, the connection that they make in that conversation can be quite generative in terms of, because you find that people don't always talk about or communicate in the communities about their illness with the family fully. Then the NHS system also has certain barriers in terms or protections for patients to kind of manage that. But it's so those kinds of challenges they're silent and people do talk about them, but I think it takes a long time for people to talk about their illness, and they're often focusing what we found, like in the conversations, a lot of the time they were more worried about, for example, one of the cancer patients was has a lot of illness in the family, a lot of problems in the family, like with the children, with the husband, and so the kind of her own sense of self and self-esteem is kind of part of that conversation. And when the cancer champion is connecting with her, I think that's also sometimes the frustration with the champion and the patient, that connection gets a little bit, it's hard because obviously they're listening, but they're not counselors. So it has to be a co-created conversations between the two of them, and the match is quite interesting, I think, in terms of when we match people, and some thought has gone into it with that thing. I don't know about your father, whether he had an opportunity for to connect with community cancer provision. What we found quite a lot with our patients was the people they spoke of most highly was Macmillan.
Macmillan, he was of the dying, and they come in and how are you, Mr. Fine? Fine. I thank you.
To be honest, the case study that I was talking about, that particular patient, that's how she answers a lot of sometimes. It was quite hard to get her to open up emotionally on some of those from the recordings, obviously, because it's the champion that's doing it. But it's a good point for us to think about how you can how a toolkit can incorporate points relating to that, like they're aware of that, and how they can maybe open them up more to speak about these things. Yeah.
Sorry, can I just add here? Sorry, I couldn't hear all of what you were saying because it's quite quiet at the back of the room there, but I think I heard that your father passed away, and I'm really, really sorry. May Allah grant him Jannah. And this whole idea of, I think what struck me a lot with our patients and caregivers is there's an epidemic of loneliness in some way that they're all trying to navigate. So we have a patient who's actually, so we have a caregiver whose father has prostate cancer, and she's caring for him, doing a lot for him, but she has no idea how his treatment's going. He refuses to talk about it, and it's because there's these massive there's social pressures of shame, the nature of the cancer first of all, but also because he doesn't want to come across as weak. And then across every single one of our patients, there's always this level of loneliness that they're navigating, and if they do share, that they kind of only do that to a certain level, to a certain extent. But interestingly, what we have found is that coping and resilience for a lot of our patients comes when it's tied to their faith. So even if they feel like they cannot talk to their mothers, their partners, their children, they then resort to their prayer mat and to Allah. So that's a really interesting thing there as well, like how they navigate loneliness and the absences in communication elsewhere, and where they lean on faith and where they decide to lean on others. And when they do lean on others, how faith and their culture is closely intertwined with that. So yeah, I don't know if I answered your question. I couldn't actually hear a question. I feel my heart goes out to you, and yeah, we hope that the research that we do really does help people have more compassionate, empathetic conversations with their families and community members, and it's something that we're really trying to improve.
Yeah, one of the, just to add to that, one of the findings of our project, it's a very sad finding, is that a lot of South Asian men didn't come forward for the study, for the recruitment of the patients and the cancer champions. It was women.
Yeah.
Women came forward. So that's a finding.
So I think we should, yeah, we're just going to, so Laura, did you have a question online? Do you want to? And then we'll come to that. Yeah.
Yeah, thank you very much. Can you hear me okay?
Yeah.
Great. Thank you very much for the really fascinating presentation. I suppose I also had a question around language, which was about the use of this word empathy, really, and why this was the word that that seemed to speak to what the project was trying to capture. I mean, it's a word with a very interesting heritage of its own. Only first translated into English in the early part of the 20th century, and in some ways has quite a kind of universalizing structure around it. So I'm interested to hear what it was about empathy that spoke to you, and whether there are words that are, what would the kind of translations of empathy be across the different languages that you're looking at?
Okay, thank you, Laura, for that question. It's a good question, and I'm thinking in my head, like, I have a lot of answers. Where do I start? I'll start with the last point. You said I thought about the word in Urdu, and hamdardi is the one that I would say, which is kind of like a hamdard, share, a kind of empathetic. But I think the question and about sort of empathy is used quite a lot in health, and maybe Peter might want to come into this as well in relation to well, empathy is used across the board, isn't it, from business to health to everything, and it's as kind of also post-colonial scholars coming into this, it's also a word you're kind of suspicious of in terms of its critical connotations. And I think what we found in a lot of the literature relating to medicine is, well, with, like, if you go into the field of doctors, etc., there's also empathy burnout as well, for example. So this idea that empathy is available for people to connect with, to be able to, in a vacuum, isn't really the way that it operates, right? People have feelings in addition to empathy. It can be negative empathy, it can be positive empathy. And does empathy lead to action? And what kind of, what happens in a kind of participatory situation? So I think what we wanted to do with the project was to kind of see when people, exactly what you said in terms of what happens to that kind of idea of empathy in a sort of context where it's not the word that people are collecting under, you know, they're collecting more under kind of shared cultural values, and empathy is part of the process of like the connection with narrative and each other's stories. So it's the connection for us very much in the project was to the idea of narrative and how people connect to stories and messaging and health messaging. And therefore, that's, I suppose, one of the reasons why we sort of selected that word. But I will also let Peter speak to it because he kind of set the background at the start. So he might want to have a more focused sort of response than my rambly one.
No, not really. Just to say, I mean, Laura's exactly right. I think, you know, empathy as a as a term has a quite short history, but bleeds back into sympathy and all sorts of things in the 19th and 18th century. It's also kind of a particular kind of Euro-American thing, if you like. I mean, so the reasons were twofold, really. One was what Amina said, which is that it's a buzzword within health, for example, as I mentioned earlier on. And so we wanted to understand a little bit more about how it was being used there and what the potential was. The other thing is to go back to that point about relationality. This project, along with the one I mentioned at the start, the one we did before, Muslims, Trust and Cultural Dialogue, the cultural part is the same, you know, or carries across. But the relationality of empathy and trust, in both cases, was what we were interested in. You know, the spaces between people, between communities, different communities sometimes, or within communities, as in this particular case, was the space we were keen to explore. And I remember, Amina, do you remember this? We had with trust, we had quite a long conversation about what was the sort of Urdu equivalent. I think was it Amana or something we came up with in the end? So there's always that sort of lack of exact fit between concepts and words across difference. But in a way, that was the sort of gritty bit that we were interested in exploring a little bit. The other thing I would say, and Amina, I think you went off with this book. I think you've got this book on you somewhere there. The Bacha Mesquita work on this is very interesting because one of the things that she says, I mean, she talks about how these concepts are always cultural, and therefore you're never going to get a perfect fit, and that the understanding and the humility, if you like, in the face of difference has to always be there, which is one of the reasons why I would never suggest that this project has now, you know, put the lid forever on this question, because it's always going to be the case that cultural difference and unfamiliarity and a degree of unease is also part of the communicative process. And that's one of the things that I quite like about it, really.
Yeah. Thanks, Peter. I hope that answers your question, Laura, which is a great question. Thank you.
The heart.
Thanks, Amina and Farah and team for the presentation. I just have a very minor question about code switching and not about the larger project. But did you ever, like, when you were studying code switching, did you ever note that the kind of functional distribution in language that you described was disrupted when people perhaps switched to English to express their frustrations with faith and personal conflicts and belief and kind of just, you know, grappling with the reality of a cancer diagnosis?
Yeah, interesting question. In this particular case study, I feel like she did a lot of that in Urdu actually, or like, I felt like there were points when she would use Urdu, almost like it was. I mean, this is my interpretation, right? It was almost like she knows that they won't be, nobody else will be able to understand it. Do you know what I mean? So she'll use Urdu if she was doing some kind of complaining, but she also complained in English. And English is a great language to complain in anyway, especially about the NHS. So
She
yeah.
was great because she,
Yeah.
at one point she said in a conversation, "Can I name the doctor?"
So yeah, I think she complained in all languages, but it's a really good point. Like,
But
something.
also she was complaining about South Asian. So South Asians complaining about South Asians, right? So it's about sort of internal kind of expectations, beyond high expectations from your community to deliver, and also then, yeah. So it's very interesting, and I think there was one patient actually, our terminal sort of patient who Eva did go to visit outside the mosque setting, and the mosque. They were sort of coming to this mosque for the conversations, but they were a revert, so they also belonged to another mosque. So, for example, they were, and in that sort of masjid, the zikr is very a more kind of Sufi context is more practiced. So they didn't talk so much about that here, but when I think Eva was visiting her, they had like a really deep conversation about philosophy and Islamic practice and kind of different. So setting can like sometimes have an impact on, if that's the question you were asking in terms of you also code switch, you know, from where you are to your environment in which you're in and the kinds of things that you would talk about. So that was.
I mean, yeah, go on, Eva.
Yeah.
Can I just add there, because my mind is buzzing right now. Also, Farah, can we click off the presentation, because I want to zoom in on you guys. Is like, I can't see you guys, but you're like a tiny icon. Yeah. So Farah shared a fascinating case study of ours with our patient. There's another pair that I absolutely adore. So these are two young girls. So one is Somali and the other one comes from, I think, a Tanzanian background. They speak Arabic anyway, and a lot of they're young, they're university students, and the patient is the Somali caregiver. Sorry, she's speaking on behalf of her mother who has ovarian cancer, terminal cancer, and this family they feel very let down by the NHS because the diagnosis was missed, and she holds a lot of like rage and frustration about everything that her mother's going through. And their conversations are actually really fascinating because comforting words are spoken in Arabic. That's when it's spoken, but all the rage and all the frustration that comes out in English. And then she kind of has to calm herself down a lot of the time by, interweaving Arabic and then, mentioning like a Quranic verse or something. So that's really interesting. And that makes us think about, age and how much age plays into that factor, not just the setting, because you have to understand as well, like they're in a masjid, they're complaining in a masjid, and Islamically as well, they have this awareness that, we shouldn't really backbite, we shouldn't really talk badly about others. So Amina's point there as well about like the setting and the mood and the things that they reveal both in English and their native mother tongues really plays a part. So yeah, I hope that helps answer your question as well.
Thanks, Eva. And it reminded me of a point, about the Somali context, because the cancer champion, when we were in a kind of informal setting with them, was talking about language, and she said that we were talking about mental health, and she said she said you just can't talk about the word. I can't remember what the word is in Somali, but she said this is the word, and she said just people will not just attach to it because it just classifies you in this context, and which made me think of like an Urdu word, and I said, oh yeah, I get it, like that's why people, in English you'd use mental health, which is a very nice word, but in other languages it may be quite different. Or
First off, thank you so much for an excellent presentation. This is really a fascinating project, and I'm particularly fascinated with the part about language and code switching. And many of the questions that were asked also, I was like, yes, I was wondering about the untranslatability of some words, including the words that are of Arabic origin, that do have like faith connotations.
Yeah.
But I was wondering whether but before actually I ask my question, I wanted to also add I really love how your framework of empathy and also integrated with faith really moves away from a framework of helplessness. Because often when you like tawakkul ala Allah, like just kind of leaving your faith exactly to God is often mistaken for helplessness. But in this case, it's not that. I was wondering whether some of the patients not mistook, but experienced some people mistaking empathy for pity when kind of trying to extend that empathy, because you spoke of empathy burnout, and I was wondering of who can afford empathy, to feel empathy and extend it all the time, especially when they're overworked and exhausted and underpaid. So yeah, just kind of the question of pity, because often that's
Can I take this? Sorry, guys. Feel free to kick me out. So there's two things that come to mind there. So firstly, there's a code we created called, or two codes: helpful behavior of professionals and unhelpful behavior of professionals. So there's how patients react to their diagnosis experience and their whole treatment journey, and how they kind of interpret how their clinicians and healthcare professionals have reacted to them. So in most cases, they react pretty fine. They understand that the healthcare professionals are really overworked, underpaid, and they only have like a 10-minute slot with their GPs, etc. So they get it. There are times when the patient feels like they've been wronged, like misdiagnosed or late diagnosed. That's when it kind of they feel like they've just been fobbed off. So there's that there. We also have, outside of that though, empathy. So we were having a conversation as a team a couple of weeks ago about how actually the individual and how empathetic they are can also have an impact on how they receive empathy as well. So we have a patient, for example, who had breast cancer, and she had a mastectomy, and she is she's a woman who's gone through many trials in life. She's suffered from many health conditions, and she feels very let down, not just by the NHS but everyone, the Muslim community, her family members. So she feels really, really isolated. So in fact, she said there's a direct quote I looked at yesterday from her where she said, they have sympathy for me but no empathy. They pity me. So there's that thing. And she's always said as well, like, no matter who talks to me about my experience, they're never going to understand, because I'm the one who's gone through it. And because of that, she has a very, very kind of like she's very guarded. So this whole idea of empathy as well, I mean, we can have ideas about it, but then there are the frameworks that exist within the patient or the caregiver or the champion themselves that allow them to engage with it in a productive or destructive or way. So yeah, that's been really interesting for us to look at.
Thank you. Thanks, Eva. Yeah, absolutely. That sort of relationship, Eva's kind of spot on with that example. And I think we found that that sometimes that can be like, if the champion and the patient, if that patient already has a quite strong sense of they're not empathetically treated, it translates into that sort of conversation connection as well, that they are already feeling quite, I think that's what we were talking about in the kind of group meeting, as to how to best approach that situation. But I think the other thing that's really useful in the focus groups is that, we're listening to the conversations, but when we're there then with the champions, we're also asking them about body language and what happened in the room, because that also can, different degrees of empathy, right? Were you looking at your phone while you were recording, or were you?
Peter's got his hand up at the
like
minute.
that, but also bigger things.
Just to say, Peter has his hand up.
Yeah. Well, it's just sort of, disclosure time. It's that thing where, if you present a paper, you say, okay, what were the shortcomings of the project? But we did make a decision early on to do audio recording and not to stick a camera up in the room, because we thought that would be a bit more intrusive. But because of that, we had to kind of reassemble after the fact, as it were, through the good offices of the champions in the focus groups where we all got together to reflect. We had to sort of reassemble things like body language, and we did actually talk through that quite a lot, and the champions themselves would mention it. But in terms of, you know, being in the room and actually seeing that in action, that's the bit that is missing. And maybe in another iteration of this project, you know, that could be another way to do it, so that you get the full range of communicative, you know, expressive stuff that goes on in that kind of space.
Yeah, I will say though, just in our defense, even because we couldn't have a camera in the room, also it really helped us having the audio recorder. So we had a little are they called dictaphones? We had that, and it was on the side where they'd forget it was in the room. But afterwards we asked them to upload the conversation onto our secure portal, and there was a little box called champion reflection. So the champion, we tell them within 24 hours you have to upload this, and remember, write down everything you remember, like whether they were crying, whether you gave them a hug, etc. So that mode was really, in the absence of us having a camera in their face, that was really helpful. And then to also add as well, Amina mentioned the focus groups. That was insanely helpful for us because we had 4 dotted across the 13 months, and the champions sometimes would be really like scared to approach topics or give their opinion. And so a massive part of the focus groups was to generate new prompts and tailor it specific to the pair, and help them with that. So yeah, and it goes back to that question of empathy. Like they were trying their hardest to connect, and every pair had a different circumstance. So the focus groups are really great in helping us generate new material that helped them have productive conversations.
Thank you very much. I think probably we need to draw at least the formal. We can carry on chatting afterwards. But thank you so much to the whole team in the room and virtually, and it's been really interesting. And we look forward to the toolkit and further conversations indeed. So thanks very much.
Thanks everyone.
Bye.
Thank you. Bye.
Thank you. Thanks.
Shall I close it now?
Everybody just say.
So I was wondering if the recording will it have caught the
So the recording,
Versus.
the